Hello everyone. Today I'll be talking to you regarding tricuspid and pulmonary valve disease, that is TSTR, PS and PR, and I'll be also covering pulmonary arterial hypertension. So first of all, tricuspid regurgitation. What are the causes? But before causes, just a very brief about TR. TR means during systole, ideally, the blood should go from right ventricle to the pulmonary artery. But here, some blood goes to the pulmonary artery and some blood goes back to the right atrium. It is exactly what happened in aortic, what happened in mitral regurgitation. In MR, the blood was going to LA, some going to aorta. It is the other way around. It is some blood going to RA and some blood going into pulmonary artery. In MR, the blood goes to LA, and in TR, the blood goes to right atrium. So cause is functional. It's a commonest cause of TR. This is again a very important point to know. Well, the commonest cause of MS, MR, AS, AR and TS is rheumatic heart disease. But TR is the one exception, with the commonest cause is not RAD, but it is functional, and this is seen in cor pulmonale. Let me explain to you. So what happened in cor pulmonale? The heart get enlarged, right atrium, right ventricle get enlarged, and that lead to stretching of the annulus, and that's why these valve cups, they are not able to fuse to close completely, and the gap is there. A gap is there, and that's the reason. That's the reason why the blood can leak from right ventricle to right atrium. Second cause is, it may be there in pulmonary hypertension. Rheumatic heart disease is definitely a very common cause. Endocarditis, this is one which can lead to even acute tricuspid regurgitation. Carcinoid syndrome and Epstein anomaly are the other conditions where we can have tricuspid regurgitation. Okay, this is very, very important. Cannot afford to forget these two. Out of these also, this is much more important. So friends, in this, the carry home message is 1, 2 and 3 are the three keywords that you got to note and remember. Now, what are the symptoms? Usually fatigue, it's a non-specific, okay. Pain on exertion in right hypochondrium due to more congestion of blood in the liver. Well, let me explain to you what is this. This is the inferior vena cava, and this is the hepatic vein which drains into inferior vena cava. This is the liver. So in TR, the blood goes from right ventricle to right atrium. Again, right atrium is a thin walled chamber. It cannot accommodate, it would try to accommodate blood, but in due course of time, blood start going backward and backward. The liver get more and more blood goes to liver, and that's why when the extra amount of blood goes to liver, the patient may have pain. But that will also give you a classical finding on palpation, which I'm going to discuss in a minute only. Edema feet, again, all because of back pressure and due to same ascites. All these are back pressure effect. Backward flow, backward pressure, whatever you can say, all because of backward flow is there. Now signs, you get a giant V wave. We know very well that V wave is due to passive filling of the right atrium. Okay, so now extra amount of blood is coming into the right atrium during systole, so you will get a Prominent V wave is a very, very important clinical sign of right ventricular regurgitation. Prominent wide descent in JVP, and because in the neck are again basic, large amount of blood has come to the right atrium in systole. So during diastole, when this opens, suddenly large amount of blood will enter into the right ventricle during diastole, and that will produce a prominent wide descent. We know very well that a wide descent is produced due to opening of the tricuspid valve. Pulsatile hepatomegaly, I just explained to you the mechanism. Large amount of blood goes to the liver also, and that goes in systole. So you get systolic pulsation in the liver, so-called pulsatile liver. Jaundice, ascites, right ventricular heave. Right ventricular heave occurs due to right ventricular hypertrophy. And this will give you what? This will produce heave at what place? It will produce left parasternal heave. Parasternal heave. This left parasternal heave is due to right ventricular hypertrophy, and this we got in mitral stenosis also. So out of these, what all is important? Giant V wave, prominent wide descent, and pulsatile liver. These three are the most important thing in tricuspid regurgitation. 1 to 3. Now we get a pansystolic murmur. Well, you got a pan. Now if I tell you what are the causes of pansystolic murmur? Pansystolic murmur we get in mitral regurgitation, we get in tricuspid regurgitation, and VSD. These two are the very close competitor to each other. So let's see how we can differentiate this. So now first of all, it is heard best in the left lower sternal H. In contrast, MR murmur is more in the best in the apex, heart apex, and it radiates to axilla. That's a classical, and this increase on expiration. The intensity of murmur increase on expiration about MR. But here the location is left lower sternal, but it increase in inspiration. But it is such an easy thing to talk. But in actual practical, when we are actually seeing the patient, this may not be at left lower sternal. Why? It may or may not be there. Let's learn the basic. I just told you that this can be, the commonest cause is cor pulmonale. So in cor pulmonale, what happened? So now cor pulmonale. Believe me, okay, 99% student, they don't know what is cor pulmonale. So I give 30 seconds to all my students, to all my student friends, young friends, write down the definition of cor pulmonale. Question only for the student. Write down what is the definition of cor pulmonale. 30 seconds. Write down quickly. Okay. So the definition is, it is the right heart, particularly right ventricular enlargement, with or without failure, with or without failure. That means there may or may not be right ventricle failure. Secondary to lung parenchyma, pleura, or chest wall disease. So, cor pulmonale, the definition is it is right heart enlargement, so-called right ventricle enlargement, right? Okay, we can even say right heart. Actually, what the books they write is right heart enlargement. Of course, heart means right atrium also. Okay, so the right heart enlargement with or without failure. That means there may or may not be right ventricle failure, plus minus. Secondary to lung parenchyma, pleura or chest wall disease is cor pulmonale. So let's go back. This is the heart, this is the tricuspid valve as I mentioned to you. So this get enlarged, so the annulus gets stretched up, and that's why blood leaks, the point what I mentioned to you, right? So now, due to, as we know, the cor pulmonale is the most common reason, and the right ventricle is getting enlarged. So what happened? It may even, suppose this is the place of the right ventricle. Now it is getting enlarged. It may go toward the apex also. If the right ventricle is very enlarged, so quite possible is that the murmur may be heard near at the apex or near the apex, not in particularly in the left sternal border. Now the $1,000,000 question is how to differentiate. It is again both are pan-systolic murmur, MR and TR. And now come the use of dynamic auscultation. Dynamic auscultation. So in such scenario where you are sure about it, but now the question, what is the idea? How will you think that I am dealing with a murmur of TR? Before that, you already have seen the JVP, and you are getting prominent V wave. Remember, in case of you are getting prominent V wave is a finding that we see in TR, and we are getting murmur, and now you want to confirm it, maybe near the apex, although it is not there, but it can be there. So now in dynamic auscultation, we ask the patient to take a deep inspiration. All left-sided murmur, they increase. All left-sided murmur, they increase in expiration. And all right-sided murmur, they will increase in inspiration. So one solid reason to differentiate between murmur of MR and TR is deep inspiration or deep expiration. The murmur of TR will increase and murmur of MR will decrease on inspiration. Okay. Well, the murmur increases with inspiration. In fact, the name has been given as Carvalho sign, especially the murmur of TR. Okay. So we understood we are getting a pan-systolic murmur, inspiration, and Carvalho sign. There are three keywords to be remembered in this particular slide. Well, there is some big controversy about Carvalho sign. If you read 12th edition of Harrison, okay, it is written that this Carvalho sign is seen in tricuspid stenosis. If you read 15th edition of Harrison, it is seen in early TR. But if you read the latest edition, they write this is the definition. The increase of intensity of murmur with inspiration is Carvalho sign. Okay. So now which is the best? So go. This is the most accurate answer. It's again my duty to tell you. So as far as management is concerned, manage the underlying cause. Definitely, as I told you, the commonest cause is cor pulmonale, and cor pulmonale is never primary; it's always secondary. To lung parenchyma, pleura, chest wall disease, you treat the basic cause, and that it will be that will take care of the TR also. Otherwise, as the right ventricle is enlarged, there may be failure with or without failure. Then we can use diuretic, ACE inhibitor, digoxin, depending on whether only this we want to decongest, we can go for diuretic, we can use ACI, it will help in the forward flow, and digoxin if the heart failure is there. So these are in use in combination or alone depending on what scenario is there. Well, valve replacement may be done, but it carries a very high mortality of about 20% mortality is there. Okay. Tricuspid stenosis. Cause is almost due to rheumatic heart disease. And whenever tricuspid stenosis is there, is always will be having some mitral or aortic valve disease. It never occur isolated. So first pathology will be this, and second will be this, and tricuspid stenosis. They are first any one of them plus tricuspid stenosis. Symptom again all due to back pressure. If you go back to the basics, blood is not able to come from RA to RV, so definitely all back pressure will be there. Fatigue, ascites edema, all back pressure. Giant A wave. Why? Atria is contracting against a narrow tricuspid valve. So you will get we know the A wave is produced due to atrial contraction against the stenosed valve. Okay, so you get a prominent A wave here and slow Y descent. In TR, it was prominent Y descent, prominent V wave and prominent Y descent. It is prominent A wave but slow Y descent, and you get a mid diastolic murmur just like mitral stenosis, but again it increases in inspiration and the muscle of MS increase on echo. The murmur of MS increase on expiration. Okay. Diagnosis is by echocardiography. We can use diuretic to decongest, and surgical repair is needed. Can be done if problem is very severe. Okay. Pulmonary stenosis. So definitely again go back to the basics. Heart, pulmonary artery, and this is the from where the blood has to go from right ventricle to pulmonary artery, and this is stenosed. So definitely blood will not go into the pulmonary artery. The problem will be of less blood in the pulmonary artery, and not to forget all back pressure will be there. The feature will be of back pressure and less amount of blood into the pulmonary artery. Cause is usually congenital. Okay, seen with Turner syndrome, very frequently asked question. Noonan syndrome, tetralogy of Fallot and rubella. In fact, these all four are very, very important. Cannot afford to forget even single one. Very frequently asked. Of course, rubella is the one that you cannot afford to forget. Acquired rheumatic heart disease and maybe carcinoid also. Okay. But one thing is there. One, you notice that in RAD, every valve can be involved. But very important point. Pulmonary valve is the least common valve involved in rheumatic heart disease. Point to be noted very carefully. Very commonly asked question, which valve is least likely to be involved in rheumatic heart disease is pulmonary valve, pulmonary stenosis to be more precise. Pulmonary stenosis is more likely to is not involved. Patient can have pulmonary regurgitation, but that is secondary to pulmonary arterial hypertension. So causes. Now signs, especially in congenital variety. In congenital variety, classically we get dysmorphic faces. But this is seen only in congenital variety. So let me explain to you what do you mean by dysmorphic faces. You can see epicanthal fold. You can see epicanthal fold. You can see flat nasal bridge. And small palpable fissure. Ears look like railroad track. Upturned nose, that means it's a flat nose, but it is slightly upturned. Okay, then thin lips, lips are very thin, and small, smooth, that philtrum, this is a smooth philtrum, the place where we have mustaches in adults. This is typically what we call as dysmorphic faces. This was a picture, and now you can see actually what I wanted to convey the message to you. You can see epicanthal fold, you can see flat, you can see small, this thing. Okay, are some of the features that are visible, ears are not visible. But only one thing you remember is what you have to remember is dysmorphic faces. This is the only keyword that you got to remember. Rest all I just wanted to show you what the dysmorphic faces look like. Prominent A wave in JVP will be there, as I told you, all back pressure. Left parasternal heave due to right ventricle hypertrophy. Ejection click will be there. Okay, that means when the patient is, when the pulmonary valve open, it can produce a sound, so-called ejection click is there. So there are the three out of these. This is the single most important thing. Why it is so important, I'm going to discuss just now. Now let me tell you what happened in mild and severe stenosis. Well, in this, there is one so-called ejection systolic murmur is also heard in pulmonary stenosis, the wave we have murmur in aortic stenosis. But there is a difference in mild and severe A. So, ejection systolic murmur, it radiates to left shoulder, point to be noted. Okay, it radiates to shoulder, and in severe cases murmur become longer. Point to be noted, in mild the murmur is short, but in severe cases it become longer. Point to be noted. Now in severe cases it may become so long it can even obscure A2. That means this is A2, this is P2, and the murmur start, ejection click is there and the murmur start, and it may go like this. It may even involve the A2. A2 may not be heard. That means only P2 will be heard. This is the ejection click, and this is the so-called ejection systolic murmur may involve the A2. So in that case, single S2 will be there. A2 is there, but that has been masked by the murmur, so you definitely cannot appreciate A2. So you will, in so severe cases, single S2 and longer murmur, longer, the two keyword. But in case of mild cases, there is shorter murmur and wide and variable splitting of S2. Wide and variable splitting of S2 in mild cases, in severe cases, single S2 will be there. So, right? So, we are very clear about it. Investigation, ECG will be right axis deviation. P pulmonale, this is due to very tall P wave. Tall P wave. Height of P wave is more than 2.5 small square. More than 2.5 small square is the height of P wave. Right ventricle hypertrophy and right bundle branch block can be there. So these are the findings that you get in right atrial enlargement, right bundle branch block, right ventricular hypertrophy, and P pulmonale. Chest X-ray, you get post-stenotic dilatation of pulmonary artery. Oligemic lung field. Do I need to explain to you? No way. I told you, less amount of blood will be going to lungs because of stenosis. And you can see right atrial enlargement in chest X-ray. So let me show you. Okay. So now you can see enlarged pulmonary trunk and the left main pulmonary artery. You are getting enlarged. That's a classical thing, post-stenotic dilatation. You can also see again prominent artery. You get right atrial enlargement is there, that we can see in these patients. Well, echocardiography is definitive to diagnose, as usual for all valvular heart disease. Treatment is valvotomy or valvuloplasty depending on what the problem is. Okay. So this is about pulmonary stenosis. Pulmonary regurgitation. Basic goes like this. This is the pulmonary artery. During systole, blood goes. Diastole, it come back again. It come back again in diastole. This is pulmonary regurgitation. Okay. So definitely the right ventricle will be bearing all the extra amount of blood. Same thing what happened in aortic regurgitation. It's the left ventricle which bear all the brunt of the regurgitation. Here the right ventricle will be getting bearing all the loads of extra blood. So now what are the causes? Any cause which can lead to pulmonary hypertension. There are n number of causes of pulmonary arterial hypertension. So they all can lead to regurgitation. And what we get? We get a decrescendo murmur is heard in early diastole, in the left sternal edge. Point to be remembered, even in AR also we got early decrescendo murmur. But that location was different, and here the location is in the left sternal edge, and this is so-called Graham-Steele murmur. Okay. Well, again, this murmur will increase in intensity on inspiration. As rule, all right-sided sound and murmur, they increase in inspiration, and left-sided murmur, they increase on expiration. Treat the basic cause of PAH, but if the valve is involved, which is very uncommonly involved, then we can go for valve replacement. But it's usually not needed. You have to treat the basic cause which is causing pulmonary arterial hypertension, about which I'm going to talk in detail just now. So a quick recap of the 4 valvular lesions we studied just now. Tricuspid regurgitation, functional, pulmonary arterial hypertension, RAD, carcinoid, and Epstein anomaly. Giant V wave, pulsatile hepatomegaly, and murmur increase with inspiration is Carvalho's sign. Tricuspid stenosis we see in RHD. Pulmonary stenosis we get dysmorphic faces, prominent A wave, and single S2 can be there. Regurgitation is caused by any cause of pulmonary arterial hypertension. Graham-Steele murmur and valve replacement is the only option, but it is usually not needed. PAH is pulmonary arterial hypertension. So again, basics. Basic is pulmonary artery. It has its own pressure, and the pressure here is 25 by 10 millimeter mercury. But when the pressure increases in the artery, that is so-called pulmonary arterial hypertension. This is the simplest thing I can present to you. But now let me tell you what exactly is PAH. So, definition is elevation of mean pulmonary artery more than 25 millimeter. Okay. Now what is this? Let me actually give you the calculation. Just now I told you the normal pulmonary arterial pressure is 25 by 10 millimeter mercury. That means systolic pressure is 25 and diastolic is 10. And now if I ask you to calculate mean arterial pressure, mean arterial pressure is MAP. How we calculate diastolic pressure? 10 is the diastolic pressure plus 1/3 of pulse pressure. Pulse pressure is systole minus diastole, 1/3. So if we calculate 10 plus 1/3 of 15, this comes out to 10 plus 5, 15. So in this calculation it is 15. It's the mean arterial pressure that we are getting. So normal mean arterial pressure is always less than 20 millimeter mercury. In our calculation I have shown you 15, definitely it is less than 20. But if the pressure goes about 25 in rest and more than 30 in exertion, this is pulmonary arterial hypertension. So PAH is when it is mean arterial pressure is more than 25 in rest, more than 30 in exertion. This is PAH. More in females, classically the idiopathic variety. This I'll be discussing soon, and typically occurs in the young ladies or middle age 30 to 50 years. So keyword is 25, 30, female and 30 to 50 years. And this is a classification by WHO. It is accepted worldwide. This is the definition which is there in all the books, in all the literature. So let us see how they group the PAH. They have grouped into different conditions. Group 1. Group 1 is, it includes idiopathic. It is this idiopathic, what previously known as primary pulmonary hypertension, right? But now the name is idiopathic. We don't know the reason why this, that's why we call it as idiopathic. It may be familial also. In around 10% cases, it is inherited as a autosomal dominant. So idiopathic and AD, there are only two keywords to be noticed down in this particular slide. Now, sometime it may be associated with, of course, we got one idiopathic, one is familial. Sometime in group 1 also, it may be associated with certain condition like collagen vascular disease. The best example I can give is scleroderma. Something unique about scleroderma. Scleroderma is one condition where there is systemic hypertension is there, and there is pulmonary arterial hypertension. Both are there. Something unique. Is not a very common phenomena to happen. Second condition where we can have increased PAH is congenital heart disease, left to right shunt, reversal of left to right shunt. That means in ASD or VSD, normally blood go from left heart to the right heart. But in very advanced stages, reversal of shunt can occur, and this is so-called Eisenmenger syndrome. The first keyword, second keyword is Eisenmenger. And something very interesting, it is seen in HIV also. PAH occur. But why this happen? Reason not known. Reason still not known. Various theories are given, but nothing is, all theories. But this happen. Sickle cell disease cannot afford to forget. Drugs, toxin, nothing special. Sometimes it can persist in the newborn. They are newborn, there are so many conditions we can lead to PAH and persist, but not important. So what is important? What is important is scleroderma, Eisenmenger, and sickle cell and HIV. These are the four things that you should not forget. Okay? Right? So the mnemonic is HIV, Eisenmenger, Hess, okay, sickle cell and scleroderma is the example that we can have. Mnemonic to remember important cause of pulmonary arterial hypertension. Group 2, this is when the PAH occur due to left heart disease. Point to be noted that we got cor pulmonale because of what? There were problem of the right-sided heart enlargement. Okay, but now he's talking about PAH secondary to left-sided heart disease. This could be left ventricular failure, or this could be mitral or stenosis or mitral regurgitation. Any pathology of the left heart can lead to this problem. Group 2. Group 3, secondary to lung disease, point to be noted. So, secondary to lung diseases can lead to PAH and COPD, especially in chronic bronchitis. It is less common in emphysema, but more in chronic bronchitis. Interstitial lung disease, sleep apnea, and ARD, high altitude ARDS. Out of these, this is the single most important thing to remember. Okay, and here only you can write down. It is precapillary type of PAH. What is the meaning of precapillary and postcapillary? I'll be discussing soon. You can write down here about this. They are the postcapillary PAH. Detail I'll be talking to you soon. Okay. Now we talk about due to thromboembolism, and the best example I can give is pulmonary embolism. This is also a type of precapillary. Of course, pulmonary artery is the problem of the lungs, but it's again precapillary. And finally, miscellaneous lymphogeomatosis, second to carcinoma, sarcoidosis. Don't forget sarcoidosis. So these are some of the important causes of pulmonary arterial hypertension. Well, now when I say anything about PAH, I'm talking about idiopathic variety, which we know it is seen in ladies, young ladies without any secondary cause is idiopathic. So unless I say about a particular disease, if I say PAH means I'm talking about idiopathic variety. Progressive exertional dyspnea is the classical presentation. Young lady of 30-35 years come to you with exertional dyspnea is the most important presentation. But this can happen in many other conditions also. But we have certain distinguished feature by which we can think, about which I am going to discuss soon. Exertional syncope, exertional pain chest also. Fine. Now, if you just cool down, if you just analyze with a cool mind, we are getting three things which are due to exertional dyspnea, exertional syncope, exertional pain chest. And if you recall your basic concept, these things are seen also in any condition which lead to left ventricle outflow, outflow obstruction, like aortic stenosis and like HOCM. There are the two other things which can have same problem of exertional. So now come the gold medal question. So now you got three important conditions where we can get exertional dyspnea, syncope and angina, the AS, HOCM and primary pulmonary arterial hypertension, so-called idiopathic. But each one have a distinct feature by which we can diagnose. All these I'm going to discuss. Peripheral edema and cyanosis occur. Peripheral edema due to back pressure, cyanosis because there is no blood is going into the lungs. So that lead to cyanosis can be there. In this, definitely the right ventricle heave will be there. Why? Because right ventricle hypertrophy is there. And now I don't need to write that this right ventricle heave occurs at the left parasternal. It comes at the left parasternal, the location where we can appreciate is left parasternal. We keep the hand in the left parasternal area and you can see movement of hand up and down with each heartbeat. Systolic ejection click will be there. And the intensity of this click increase on expiration. This is a very, very important point. Very important point. Why it is so important? Because it is a right-sided sound. Normally all right sound they increase in inspiration. But here we are getting exception. Here we are getting in expiration it is increasing. Loud P2. Everything you forget, but don't forget loud P2. If in the question you get loud P2, so 99.9% you are dealing with pulmonary arterial hypertension. Single. 1 point P2 is PAH. Okay. Raised JVP with prominent A wave. Definitely atria has to contact against a very stiff wall and that lead to prominent A wave. And there can be tricuspid regurgitation can be there. Again, back pressure. In such cases, you will start getting prominent V wave also. Well, friends, the key word to be remember here are 1 and 2. And out of this is a single most important point that you got to remember about PAH. Now, what is the pathophysiology of PAH? Of course, no need to say I'm talking about idiopathic variety. Idiopathic variety. Well, a very famous double insult theory has been proposed from idiopathic variety. What is this? First thing, in idiopathic variety, patient has abnormal bone morphogenic protein receptor type 2, what we call as BMPR2. Okay, they are the one which they call the first insult, or I can say this the one which starts the fire. It starts the fire. beginner, or you can say day-to-day example, you drive a car, motorbike or scooter, whatever you drive, you put the key and you ignite, you start, okay, you use and you start the car, and after that you change the gear and the car moves or the bike moves. This is the starting of the car, is by BMPR2, and it is this which predisposes the patient for pulmonary vascular disease. Understood? Now second insult, that is adding fuel to the fire. Adding fuel to the fire. Okay, now that will be done by any infection drugs. Any infection drugs, huge list I gave to you, they can start. Now what they are going to do? They activate the disease process, but I told you they are going the way we started the car with the key, and now the car has to move. So now the secondary insult will lead to the movement of the car, or so-called activate the disease. How come? They increase the endothelin, which is a vasoconstrictor. In fact, endothelin is the most powerful vasoconstrictor in the body. We know angiotensin 2 is also a vasoconstrictor, which is involved in the pathology of systemic hypertension. But in pulmonary hypertension, endothelin is involved, which is even more powerful vasoconstrictor as compared to angiotensin 2. It reduces the nitric oxide, which is a vasodilator. So definitely the car normally in the balance way. Normally in the balance, we have a endothelin, which causes constrictor endothelin, and we have a nitric oxide, which is a vasodilator. So these are in balance. So now in this case, what happened? Endothelin will be more. So endothelin will be more. It will cause more vasoconstriction. The dilator is reduced. So that means more and more vasoconstriction will occur. Equation is going toward the vasoconstriction. Even prostacyclin is decreased. They are again vasodilator, and they also inhibit platelet aggregation. Point to be noted, endothelin is increased, which is a vasoconstrictor. Vasodilator like prostacyclin and nitric oxide, they are reduced. Net result will be vasoconstriction. Obviously vasoconstriction will be there because dilator are less, constrictor is more, and that lead to smooth muscle proliferation in the artery. Fibrosis can be there. There can be thrombosis of pulmonary artery or arteriole. Vasoconstriction is there. They can all lead to endothelial cell growth. So ultimately, the net result will be elevated pulmonary arterial pressure. So even this one line is good enough. All these I just told you what happened in the pathology, fibrosis, proliferation. But you don't have to forget this. Vasoconstriction, and it lead to pulmonary arterial pressure. This is not good enough. Let's learn more basic. Pressure is inversely proportional to resistance. Okay, resistance is due to vasoconstriction. More vasoconstriction, more resistance. Okay, how come? How come? Resistance is 1 by R4. R is the radius of the arteriole. Narrower the arteriole, more will be resistance in any vessel. Same formula applies for peripheral resistance also, but here I am talking about pulmonary resistance, artery resistance. Arterioles are getting narrowed down, the resistance will go high, and that lead to pulmonary arterial hypertension. So just remember vasoconstriction and just remember pulmonary arterial hypertension. So now PAH has occurred, that lead to what? Right ventricular hypertrophy. The way left ventricular hypertrophy occurs in systemic hypertension. Here the right ventricular hypertrophy occurs in pulmonary arterial hypertension. So ultimately later on it leads to right ventricle failure also. First is the hypertrophy, later is the failure. Now what we see in pathology, this one question comes in all the exam. What we see, classical changes that we see in idiopathic variety, plexiform lesion. If you get in your question in the lungs, you are getting plexiform lesion. It's a golden line to remember that you are dealing with PAH, of course, idiopathic variety. Golden line to remember. Plexiform lesion in the arterioles of the lung is PAH. And this is nothing but interluminal angiomatous stuff that forms a web. This is thought to be diagnostic of PAH. Same thing I said, golden line to remember. The plexiform lesion in the lung vessel is PAH. What is this? Let me show you. Let me show you a beautiful picture. This is a normal heart. Normal heart. This is the pulmonary artery. And you are getting this is the normal, and you are a normal vessel. Everything is normal. Now look into this. This vessel are constricted. Look in this, compare with this one. Just see. That's the indication of constriction. And what you get is the classical finding of pulmonary vessel constriction, which can give you a form of tuft of plexiform lesion, is the diagnostic of PAH. Okay. So we learn a lot about the pathology, pathophysiology, and of course we learn the grading also, group 1, 2, 3, 4, 5. Now I'm going to tell you secondary PAH. Okay, that means PAH is due to some other cause. And causes and mechanisms. So far, whatever I discussed is all what I told you was in primary idiopathic variety. So let's move into secondary variety. In secondary variety, what happened? Why the net all is again due to reduced cross-section area of pulmonary arterial blood. That means again, that is pulmonary vasoconstriction occur in secondary variety also. Whatever reason it may be, that means the area is reduced, and one of the main reason is vasoconstriction. Okay, so why and how, let's discuss more detail. Now this may be vasoconstriction. This was there in primary also. But now, in that case, it was started with the bone BMPR. Now here it is due to hypoxia. From any cause. You remember when I said COPD, chronic lung disease, like chronic bronchitis. In chronic bronchitis, it leads to vasoconstriction, sleep disorder, again all due to hypoxia. So hypoxia will lead to vasoconstriction. Loss of blood vessel may be lost typically in emphysema and interstitial lung disease. We all know very well in emphysema, this is a normal alveoli. And emphysema, it all rupture and they become a single alveoli. That definitely when it is getting like this, a lot of capillaries are also lost. Okay. Obstruction of vessel is the best example is pulmonary embolism. Cannot afford to forget this. Schistosomiasis and sickle cell disease, these three are the most important thing which can lead to. Schistosomiasis is a very commonly asked question. In fact, these three are very, very important question. They all lead to obstruction, and that's why obstruction will lead to increased arterial hypertension. Increased pulmonary venous pressure. This is seen in LVF and mitral stenosis, and of course constrictive pericarditis. This I'll be talking to you in detail just now. This also I'll be talking to you in detail just now. But as of now, just remember, finally, increased blood flow, left to right shunt. Okay, and increased blood viscosity, polycythemia. The polycythemia viscosity goes very, very high because of the increased number of RBC, and that induces pulmonary arterial hypertension. Now I'll be talking to you regarding pre and post capillary PAH. In the previous slides I mentioned that in pulmonary embolism in ARDS you get a type of pre-capillary, and I also mentioned that in case of mitral stenosis we get post capillary PAH. Now what is this? This you will never understand unless we know the basic concept. The basic concept goes like this. This is the heart. This is the mitral valve. And we know very well the mitral valve area is 4 to 6 square centimeter. And average I take as a 5 square centimeter. And the pressure in this is 4 to 12 millimeter of mercury. LA pressure is 4 to 12 millimeter mercury. For easy calculation, I take 10 millimeter. And here I have taken 5 square centimeter. Once the area of this goes to 2.5 square centimeter, blood will not be able to flow freely from LA to LV. So in that case, LA pressure will rise. LA pressure will rise. This is the most characteristic feature of mitral stenosis, increased LA pressure. Well, it may go up to 20 millimeter mercury. To that time, the left ventricle LA will try to accommodate blood. But after that, LA is a thin-walled chamber. It cannot accommodate much blood. Blood start entering into the pulmonary vein. So it leads to pulmonary venous hypertension. Finally, capillaries, you get pulmonary capillary hypertension, and finally you get arterial pressure, you get increased pulmonary arterial hypertension. Got it? This is a sequence of changes that occur in mitral stenosis. Point to be noted that here we are getting PAH. This is the capillary. The problem is here. The problem is post capillary. This is the reason it is behind the pulmonary capillary. And one of the classical feature of post is increase LA pressure. Increase LA pressure. And LA pressure we can measure by pulmonary capillary wedge pressure. Pulmonary capillary wedge pressure. And this we can check by Swan-Ganz catheter. So here we get a PAH because of increased LA pressure. Now, suppose we get one patient who has got pulmonary embolism. Pulmonary embolism means this is the clot. And suddenly blockage is there, definitely it will lead to pulmonary arterial hypertension, definitely. But the problem is before the capillaries. So in pulmonary embolism, we'll be getting pre-capillary type of PAH. Point to be noted, it is before the capillaries. Here, LA pressure is normal. Same pre-capillary we get in ARDS also. This ARDS is also known as non-cardiogenic pulmonary edema. Non-cardiogenic pulmonary edema. We get this non-cardiogenic pulmonary edema. So in ARDS and pulmonary embolism, they are type of pre-capillary LA pressure is normal. This very, very important point. Having learned the basic, so now I will give you a summary of the two. LA pressure is normal in pre-capillary and LA pressure we measure by pulmonary capillary wedge pressure. It is increase post-capillary. Then pulmonary artery and LA pressure gradient is more than 12 millimeter mercury. Here it is less than 12 millimeter of mercury. Right? What do you mean by this? Basics. Again, we go back to basic. How we got this figure? So, if I recall the definition what I told you, we call as PAH when the mean arterial pressure is more than 25. Yes. This is pulmonary arterial hypertension. Whatever cause it may be, whether it's primary, secondary, like this, maybe pre-capillary, post-capillary, agreed. We also know that normal LA pressure is about 4 to 12, so I'll take as a 10 millimeter mercury. Agreed. So they are basic. And pre-capillary, in pre-capillary, LA pressure is normal. So mean arterial pressure in pulmonary artery 25, LA is 10, difference is 15 millimeter of mercury. And what we are talking is more than 12, agreed. But in post-capillary, the LA pressure is increased. Yes? Remember, normal LA pressure was about 8 to 12. Here the pressure may be even 20 or 22. Let's say 20. 25 minus 25 is there. So this gradient is less than 12. Less than 12. So I repeat again, because we medicos have a poor mathematics, including me also. I hope I have done the right calculation. A quick recap. In pulmonary arterial hypertension, as per definition, mean arterial pressure of pulmonary artery is more than 25. This is a definition. That is the PAH. A normal LA pressure is 10. We also know that in pre-capillary LA pressure is normal. So PAH is 25 and 10 is the normal. So difference is 15. This is pre-capillary. But in post-capillary LA pressure increases, like mitral stenosis has gone to 20, PAI 25, the gap is 5. So gap is more than 12 and less than 12 millimeter mercury. I hope you understood the calculation. Causes: primary pulmonary embolism, schistosomiasis and ARDS. This is the single most important so-called non-cardiogenic pulmonary edema. Here we have a mitral valve disease and left ventricle failure. This is the difference between pre and post capillary, and with the basic concept which I hope you understood nicely. Okay, if anybody has not written, you can write down. I'll hold the screen for some time. So now, how to investigate of PAH? This is again for idiopathic variety, because in secondary causes, whatever it is, like suppose it is due to chronic bronchitis, then you have to investigate in the term of chronic bronchitis. If it is due to schistosomiasis, investigate. Sickle cell, investigate. HIV, investigate. So there are a lot of other investigations, but again I'm talking about idiopathic variety, which is seen in ladies around 30 to 50 years. Let's see what happened. Lung function test. Patient has come with exertional dyspnea and all this thing. FVC normal, FEV1 normal, ratio normal. Oh, everything is normal. Since the ratio is normal, FEV1, so it is not a obstructive airway disease. I hope you know. Remember the basic lung function test. In obstructive airway disease, this ratio is less than 0.7. It is more than 7, 0.7. It's not obstructive. FVC is normal, so it is not a restrictive airway disease. So neither obstructive nor restrictive. Then what the use of doing any lung function test? Spirometry we do to rule out obstructive or restrictive airway disease. But what the classical abnormality? Diffusion capacity is reduced. Diffusion capacity to carbon monoxide is reduced. It's the classical. So normal spirometry with reduced diffusion capacity is idiopathic variety of PAH. Right? Golden line to remember. Golden line, normal spirometry with reduced DLCO in a young lady is primary pulmonary arterial hypertension, so-called idiopathic PAH. Golden line to remember. Spirometry normal, diffusion capacity is reduced. Chest X-ray, you get prominent pulmonary artery, peripheral hypovascularity. In the peripheral, you can see less and you are getting prominent right descending artery. Okay. So to so better visibility, you can see that we are getting a prominent right descending artery. You're getting prominent central artery, and periphery is hypovascularity. You can also get right ventricular enlargement is there. ECG will show you right ventricular hypertrophy or maybe right ventricular strain. Echocardiography can give the pressure area, that pressure curve that we need. As I told you, 25/10 is the normal, and it will show all the pressure changes. And there may be evidence of tricuspid regurgitation that we can see in these cases, that we can see very well by echocardiography. Cardiac catheterization is the best investigation to diagnose PAH. It will measure all the pressures. Pressure can be measured by echo also, but this can be done by more accurate. More accurate is the finding. Point to remember, again repeating second time, pressure you can see by echocardiography also. Pressure you can see by this also, but this you can see better. Can I give you day-to-day example? Yes, why not? Recall your microbiology lab days. You used to see slide. You see on the slide under low power. You can see, yes, but you use high power. Same microscope. You just turn around. Okay, like this. It is this. You turn around and you can see low to high power. Do I need to tell you, in high power you can have a better visibility, better delineation? Same thing here also. Echocardiography is a low power microscope, and the catheterization is just like using high power. Rest, you are very intelligent, you got the idea, but I want to convey the message to you. So catheterization is the single most important investigation is catheterization study. Well, as far as management is concerned, if it is due to secondary cause, you treat the secondary cause. Like chronic bronchitis, you treat chronic bronchitis. Unless you treat chronic bronchitis, PAH will never go. So in all, like in mitral stenosis, you treat the mitral stenosis, automatically PAH will go. You may have to give anticoagulation or oxygen depending on what the problem is, right? But in idiopathic variety, this is the one gold medal question. If you ruled out all other secondary causes, and we know that we are dealing with the primary, now you plan for treatment. What and how you will plan? You first do the acute vasodilator testing. This is done before you plan the treatment. What is this? What do you mean by acute vasodilator testing? We give a vasodilator. This could be intravenous epoprostenol or inhaled nitric oxide. Either you give inhaled NO or intravenous epoprostenol. They are vasodilator. Of course, they are all, when we are giving IV or inhaled, they are short acting. So you have checked the pulmonary arterial pressure before, and you give this, and again you check the PAH after giving. So we do pre and post testing of the pulmonary arterial pressure. So this is so-called acute vasodilator testing is done. Now pressure may fall or pressure may not fall. So we have test is positive means the pressure falls. Test is negative means pressure is not falling. So let us see. So if the test is positive, that means they are responding to vasodilator testing by the way we did the previous slide. these patients should be given oral calcium channel blocker. That is nifedipine, diltiazem and amlodipine. Initially they were using this, but nowadays amlodipine is more in use. Diltiazem is not that, but can be given. But amlodipine, anyway, the books have written all the three, but they are also right. Now increasingly being used is amlodipine. Now the test is negative. That means we have given the acute vasodilated therapy and they are not responding. That means pressure is not falling. Then in such cases, we go for other therapy. And you'll be surprised to know majority of them, they are into this category. And these are only minor. These respond. There are only minority of patients are who respond. Minority, less. Majority are not responder. Majority are negative. In such cases, what we give is prostacyclin analog, that is treprostinil and iloprost. You remember in the very beginning I told you prostacyclin are the vasodilator, and this got reduced in idiopathic variety. Endothelin receptor blocking drug like bosentan and embricen, you remember in idiopathic variety there was increased endothelin, which is a vasoconstrictor, and they were reduced prostacyclin, which is a vasodilator. So now we are reversing the process. We are giving prostacyclin analog to dilate, and we are giving endothelin receptor antagonist to reduce vasoconstriction. We can also use phosphodiesterase inhibitor sildenafil, which is nothing but Viagra. It is used in PAH also. Well, despite all the medical therapy, the patient is deteriorating, then you can go for the transplantation. Okay, but that's not an easy thing to get it done. However, I hope you are clear about it. In nutshell, that management of idiopathic variety, you go for acute vasodilator therapy. If they respond, give calcium channel blocker. If not, then we can give prostacyclin analog, endothelin receptor antagonist, or sildenafil we can give. Now, pharmacology of these endothelin receptor blocking drug with biochemistry also. These are endothelin 1 receptor antagonist. Okay. Well, when there is increased expression of endothelin 1, that lead to intense vasoconstriction, and that causes PAH, and they are going to block these receptor. Little bit more about a receptor. Endothelin, it act on the two receptor, ETA and ETB. Endothelin A and endothelin B. The two receptor are there. A is the one which lead to vasoconstriction. B is which lead to dilatation. So, A is vasoconstriction and B is vasodilatation. These drugs, bosentan, they mainly act, they block this receptor. They block this receptor which are vasoconstrictor. So there will be unopposed action of the ETB, and that lead to vasodilatation of pulmonary circulation, to be more precise. And that's why when they do the vasodilatation, and that's why the pulmonary arterial pressure goes down. Okay. So now when we use this drug, bosentan or embricen, both are same, they reduce morbidity and mortality. Both are reduced. Okay. Patient feel more comfortable. The exertional dyspnea, syncope, pain, chest disappear. Patient gain more and more confidence, and patient work efficiency increases. It is generally well tolerated, but sometimes they may have peripheral edema, nothing serious about it. Little bit of flushing, nasal decongestion can occur, but they are very mild problem, nothing worry about it. This patient can very well tolerate at the cost when the patient is getting so much of help in reducing dyspnea, pain and syncope. So the golden line to remember, if you get a young lady or middle-aged lady come to you for dyspnea on exertion, loud P2 with clear lung fields, normal FEV1, normal FVC, normal ratio, this is primary pulmonary hypertension. Here all the question will be based on this, plus the treatment what I told you is calcium channel blocker in responder and endothelin receptor blocking drug in the non-responder. So remember, in fact 99% they will talk about bosentan. In treatment 99% bosentan or of course calcium channel blocker. Just remember these two. This slide what you are seeing at the moment, 99% you will get question based on this particular slide.